So this chapter we're going to cover airway management and mechanical ventilation. So indications for intubation would include upper airway obstruction, such as a tumor, apnea, somebody who's at high risk for aspiration, somebody who cannot clear their airway of secretion, so maybe that have a very poor cough, and obviously respiratory distress, and general anesthesia. So there are two ways somebody can have an ET tube, either orally or nasally. The oral ET tube is preferred, has a larger diameter, which means a lower airway resistance. It's easier to remove secretions, and it's easier to perform bronchoscopies. Nasal intubation is best when there's head or neck manipulation that is risky. So somebody with neck injury, it's best for them to be nasally intubated. We really want to be careful not to nasally or have somebody nasally intubated, or it's contraindicated in patients with skull fractures or sinus problems. Most of the patients that we will see in the hospital setting are orally intubated. Usually if they're nasally intubated, it was done out in the field. And then they're mainly switched over to oral intubation if they require a little bit longer term. And then we have tracheostomy. So the longest somebody can be intubated for is about 2 weeks. By the time you reach that 10 to 14 day period, you're looking into getting a tracheostomy. And we do a whole chapter on trach, so we'll talk about why those are a little bit easier in the next chapter. So technically consent is required for ET intubation, but many times it's emergent, so consent is unable to be obtained. Unless somebody is a DNI or do not intubate, then we would intubate under emergent situations. Some of the patient and family teaching that needs to be done is about restraints. Many patients are restrained who are intubated so they don't pull out the endotracheal tube. Also sedation. It's likely that they will have medication for pain and to put them to sleep, which is comforting knowing that you have a tube stuck down your throat. And then that they will be unable to speak or drink. So methods of communication should be offered or spoke with the patient about, and letting them know that they will receive hydration via IV or they could be on tube feeds. Equipment that needs to be available is an ambu bag or a BVM attached to oxygen and turned on. So we turn that flow meter up all the way to between 12 and 15 liters when it's attached to the wall oxygen. So we can't just use an ambu bag by itself. It does need to be attached to oxygen and turned on. Suctioning equipment also needs to be available and IV access to give sedative medication. And of course, patients should be on a cardiac monitor and continuous O2 monitoring. So immediately following intubation, there's 3 things that we do to confirm placement. So that would be to listen to the lung sound, so listening over both lung fields, and then also listening to the epigastric area, because if the endotracheal tube is not in the lungs, it went down into the esophagus. So we want to make sure that it's not there. Aerating the stomach doesn't really do anything for the patient. We're looking for symmetry of chest wall movement. We get an end-tidal CO2. So there's a little device that's placed on the top of the endotracheal tube, and we should see a color change. So it detects carbon dioxide. So we put it on the top of the T-tube, bag the patient, and then if it detects carbon dioxide upon exhalation, then we know that we're in the right spot. The final thing is a chest x-ray. We get a chest x-ray to confirm placement and also to make sure that it's properly placed in the trachea. So our carina, right before the trachea bifurcates into the left and right bronchi, we have the carina, and that is very sensitive, and anytime you touch that or stimulate that, it makes us cough. So we don't want that ET tube sitting on the carina because the patient's just going to cough. Also, the tube, once we confirm placement, make sure that it's in the lungs and it didn't go somewhere where it wasn't supposed to be. We would mark the tube. So the tube is marked in centimeters. So we would need to make note about where that tube was according to their lip line. So there's centimeters such as like 25 centimeters, 23. So that way if it got pulled out, we would know, or if it was pushed back in for whatever reason, we would also know. This is part of respiratory therapy and our job to know where that tube sits. And we can get ABGs to determine if the ventilator settings are appropriate for that patient. We usually always get follow-up ABGs to, again, make sure that those ventilatory settings are appropriate. And of course, we want to continuously monitor pulse oximetry, and many patients are also placed on end-tidal CO2. So it measures the amount of exhaled carbon dioxide. So it's an easy way for us to detect changes in respirations before it really starts affecting their hemodynamics. Another very important job of ours is maintaining the tube patency. So we will never, ever see anything that says, suction the patient's ET tube Q4 hours or Q shift or Q2 hours. We don't routinely suction the patient. We only suction them when they need to be suctioned. So how would we know if they needed to be suctioned? There's multiple ways. Sometimes there's visible secretions in the endotracheal tube. That's a gimme, right? If you see them. Sudden onset of respiratory distress. Maybe they have a bunch of crap in their lungs. Increased peak airway pressures. So the ventilator would alarm that it's having to push harder, or it's having to increase its pressure to push air into the lungs. Most likely it's having to do that because there's mucus in the airway. So removing that mucus will make the ventilator work less hard to push the air in. So that would be peak airway pressures. Any adventitious breath sounds, especially rhonchi. If we hear rhonchi, that would be an indication to suction somebody. A sudden decrease in their oxygen levels, so their SpO2 dropped or is steadily dropping, may indicate a need for suctioning. Tachycardia, increased respiratory rate, and coughing as well are all indications. To be honest, many times you can hear like the rattle in the endotracheal tube when patients need to be suctioned, when they have a lot of secretions. The bottom picture is really nice because this we can see the closed suction technique. So this is the most common on ventilators. So that suction catheter is in that bag, the catheter sheath, looks like the picture tells us. So the catheter is actually kept sterile. Anything that goes into our lungs must be sterile. In our GI tract, not so much, but anything, every time that a catheter goes into our lungs, we need to make sure that it's sterile. So this sheath over the catheter allows that catheter to stay sterile, and that is the closed suction technique. We go over open suction when we talk about trachs. So we don't routinely suction patients because there's a lot of complications that can happen from suctioning, such as mucosal damage. The more times we go down there, the more we're irritating the lung tissue. Hypoxemia and bronchospasm. So the more we cough, the more mucus we secrete, right, to try to propel that upward. It's just a natural body response. So the more we stimulate the cough, the more they're going to cough, the more they're going to bronchospasm, or we could initiate bronchospasms. Increased ICP. So we're really careful with patients with head injuries and suctioning them. Dysrhythmias. Patients who are super sensitive to oxygen changes. I mean, we are taking that patient's breath away every time we suction them. So patients who can't handle that and are really unstable can actually have dysrhythmias while suctioning, like ventricular dysrhythmias. Sometimes they'll have a run of VTAC. You'll see the patient have some PVCs. It can affect blood pressure, again, for those patients that are really unstable. bleeding, pain, infection especially in that open suction technique. So obviously there will be times when we will have to suction the patient. So there's a couple things that we can do to help prevent some of these complications during suctioning. So we're going to go over those on the next slide. All right, so in our little ivory tower where we're all sitting right now, we always hyperoxygenate the patient before suctioning and after suctioning. So we hyperoxygenate with 100% FiO2 and only for about 2 minutes. So you're not going to hyperoxygenate the patient and then go take your 15-minute break, right? You're going to hyperoxygenate the patient, stay with them because it's only going to be for a few moments. The other thing that's extremely important is limiting each pass to less than 10 seconds. So we do not want to suction a patient or have that catheter down there any longer than 10 seconds. Again, because we're literally taking the patient's breath away. What I like to do when I suction somebody, and a respiratory therapist actually suggested it, is to hold your own breath. Because if, and don't take a big gulp ahead of time, just breathe normal and then hold your breath, because that's what you're doing to the patient. So if you can't tolerate it, then you know that you're suctioning them for, too long. We also want to continuously monitor them. If we see that they're not tolerating the suctioning for whatever reason, if they have a severe decline in their SpO2, dysrhythmias, severe changes in their blood pressure, clearly we don't want to be suctioning them. So what we would do is we would stop the procedure, wait, and then attempt it again at a different time in our NCLEX ivory tower here that we're all in. So our major complication of intubation is unplanned extubation. So either that tube gets removed accidentally, maybe during repositioning, or the patient's able to grab a hold of that and pull that endotracheal tube out. Even with sedation, I mean, you have to think that a lot of those medications are amnesic, they cause us to forget. So if a patient wakes up for whatever reason, or has some lucidity, they're going to think that they're suffocating, and our natural response would be to pull that endotracheal tube out. So we always want to be aware of that and not, yell at the patient for ripping that tube out, because sometimes they just don't know. So other than sedation, we may use restraints again to prevent unplanned extubation. So how would we know if this happened? Well, the patient would be yelling. Activation of low pressure alarms. Atmospheric air has a lower pressure than the air in our lungs. So the vent would alarm. You would hear all these bells and whistles going off that there's low pressure if the tube is out. Diminished or absent breath sounds. This can happen if that ET tube maybe got pulled out and then went back into one of the bronchi, mainly the right bronchi because it's a little bit straighter, or that tube, I don't know, migrated somewhere else. Maybe it got pulled out and it's no longer, it's no longer in the trachea where it needs to be. Respiratory distress and gastric distension, which would happen if that ET tube was in the esophagus. So if this happens, what do we do? So we never leave the patient, so we have to stay with the patient. We would manually ventilate the patient with 100% FiO2. So we have our bag valve mask, our BVM at the bedside. So we would hook that up to our 100% FiO2 and bag the patient. We would make sure that any sedation is turned off, because we want patients to wake up so they can breathe on their own. Calling for help, and then really kind of staying calm so the patient stays calm. And that's really important for their, their respiratory. So indications for mechanical ventilation are to be intubated. We went over these on the first slide. But just to reiterate, apnea or impending inability to breathe, so some sort of respiratory distress, respiratory muscle fatigue. Sometimes patients can, have musculoskeletal disorders such as MS that will prevent them from breathing. It affects their diaphragm. Our ethical decision to use or not to use is our DNIs. There also comes the ethical decision when to, extubate somebody who is not improving, so to terminally extubate them. So there's a lot of ethics that kind of go around mechanical ventilation. So there are two types of mechanical ventilation. There's negative pressure and there's positive pressure. So we're going to cover negative pressure first in the first two slides, just so you can understand the difference. So you will not have any test questions on negative pressure ventilation because we don't really do it anymore. But I just want you to understand how it's different than positive pressure, and it kind of helps us understand the positive pressure more when we have something to compare it to. So these types of mechanical ventilators are non-invasive. So there's no airway. What happens is they have this machine or suit or whatever it is that encases the chest or the body, and there is different pressures within those chambers, whatever's encasing the chest or the body, that pulls the chest forward to allow air in, and then also allows for passive expiration. So it's very similar to normal ventilation. Let me show you a picture on the other side. This is more of a modern-ish. You can tell by the sheets that it's probably a little bit older, but you can tell that this is something that we don't see very often, but this is a picture of a negative pressure ventilator. So it's non-invasive, but she's wearing this suit, I don't know what else to call it, that encompasses her body. And then there's different pressures within that suit that allow the chest to rise and air to flow in. So there's a video that I'm going to post on Banner just about the iron lung. You can watch it if you want to, but the iron lung is negative pressure ventilation. It just goes through, negative pressure ventilators were the first that were used. They were used widely during the polio epidemic. So it's just I like stuff like that. I like the history. But now we'll move on to positive pressure ventilation, which we will see in the hospitals. So positive pressure ventilation, or PPV, is what is used in acutely ill patients in the hospital. So this is done, obviously, invasively through an endotracheal tube. It delivers air into the lungs under positive pressure, so it's air that we are pushing into the patient's lungs. But then expiration occurs passively. So the ventilator doesn't pull out the air escapes, not on its own, but through normal ventilation. So the settings on our ventilators, we're able to regulate rate, depth, and then many other characteristics of ventilation, which we'll go through, such as obviously tidal volume, the percentage of FiO2, we talk about PEEP. It's really based on the patient's status and why they were intubated in the first place. Was it for hypoxemia? Was it for hypercarbia? So depending on the reason, really, we can change a lot of settings. So some of the settings on our ventilators, respiratory rate, tidal volume, FiO2, or the percentage of oxygen, room air is 21%, right? And then PEEP. We'll talk about PEEP in a little bit. The other things that we're able to regulate is the amount of pressure that we use to force air into the lungs. But not all of these are always set on a ventilator. It depends on the type of PPV that these patients are on. So the next couple slides, I'll give you an example. So the different modes that we use for mechanical ventilation really, again, depend on the patient and why they were intubated in the first place. So we determine this by the patient's ventilatory status, their respiratory drive, do they have the ability to take their own breaths, and their ABGs. So one of the different kinds, or the mode of PPV, is volume ventilation. So volume ventilation allows us to deliver the same tidal volume to the patient every breath that they take. So this can be dangerous for patients with really stiff lungs who have a lot of crap in their lungs. So it doesn't matter the amount of force that the ventilator will have to use to push air into the lungs to maintain that tidal volume. So we can actually wind up damaging the lungs if patients, if we're having to use a lot of pressure to deliver this tidal volume. So this is just one of the modes. So it has a set predetermined tidal volume, and then it depends on the amount of pressure the ventilator sets to achieve the same tidal volume with each breath. In contrast, we have pressure ventilation. So this is where we set a predetermined pressure for the patient, but the tidal volume will vary because maybe, I set my pressure at 10, let's say. I might get a tidal volume of 200 with one of my breaths, and then the next breath I could get a 550 tidal volume. So it's really easy to hyper or hypoventilate these patients. Patients who are on pressure ventilation oftentimes are on paralytics. That way, the ventilator, we can make sure that is doing all of the work. So we are really just taking over their respiratory system, basically. In addition to the different modes, we're also able to have ventilators do all the work of the patient or kind of share the work of breathing. So sometimes patients can take their own breath and they're doing most of the breathing, but the ventilator will give them just a little bit of extra help. So sometimes that's more, we see that more with weaning when we're trying to wean patients. So there's many alarms that are set on a ventilator. We're just going to go through a couple of them. So the main ones are high pressure and low pressure alarms. So respiratory therapy or the therapist will set the alarms on the ventilator to let us know if something is wrong. So usually a high pressure alarm will indicate that the ventilator is having to work harder to push air into the lungs, aka if the patient has secretions. Sometimes if the patient is coughing against the ventilator, this alarm will bing. Low pressure alarms generally are because that tube, was dislodged, came out. And then there's also other, alarms that are set, kind of like our hemodynamic monitors that we have, or even just our regular monitors with heart rate. We always set our alarms. It's the same sort of concept with ventilators. All right, so let's talk about PEEP a little bit. So PEEP is positive end expiratory pressure. So it's the pressure pushed into the alveoli at the end of expiration. So when we talked about our alveoli and our respiratory assessment, we made the conclusion that our alveoli like to collapse. They have a natural tendency to collapse. So if I didn't have PEEP, every time I exhaled, those lazy alveoli would just close right up and then I'd have to start all over again. So we have PEEP. So PEEP is what keeps those alveoli from totally collapsing when we exhale. We have natural PEEP in our bodies, so we have PEEP, all of us. And then we also have PEEP that can be controlled by mechanical ventilation. So if my alveoli are still open at the end of expiration, there is still gas exchange that's taking place. So the larger my alveoli are, the more PEEP I have, the more pressure can improve oxygenation because my airway, my alveoli are open more, and that is still participating in gas exchange. So we have the ability, when somebody's intubated on mechanical ventilation, to improve their oxygenation by not increasing their percentage of oxygen, their FiO2, but mainly maybe by increasing their PEEP a little bit. PEEP sounds so wonderful. Like, why don't we just give everybody lots of PEEP? So there are some contraindications and there are some complications of having high PEEP. So it's contraindicated in patients with highly compliant lungs. So lungs that are very, they don't have the elastic recoil like COPD. Unilateral or non-uniform disease. So if I am pushing a lot of pressure or have a high PEEP on patients with, let's say, unilateral lung disease, that other lung is still going to have that high PEEP. When you're intubated, the air is for both lungs. right? We can't really say, oh, no, pressure on the right lung is going to be this and the pressure on the left lung is going to be that. So that's why that is contraindicated. Hypovolemia and low cardiac output are kind of for the same reason. So the more PEEP I have, the greater the pressure in my intrathoracic cavity. The greater the pressure in my intrathoracic cavity, the harder my body has to work to return blood back to the right side of my heart. So that therefore resulting in low cardiac output. So for patients with already a low preload, increasing their PEEP could also decrease their cardiac output. So our natural physiologic PEEP that we have is anywhere between 3 and 5 centimeters of water. So when somebody is mechanically intubated, usually the natural PEEP or the lowest setting is 5. And then that can be titrated up to reach an optimal, depending on the patient and why they were intubated in the first place or need mechanical ventilation, that can be titrated up to achieve an improved oxygenation status. So we're going to talk about CPAP and BiPAP in these slides as well. So CPAP is different from BiPAP because CPAP is just one pressure. So it's one continuous pressure. It's used a lot to overcome airway resistance that can happen when we're sleeping, like in obstructive sleep apnea. We can deliver just that one pressure non-invasively through a mask, or ventilators actually have a CPAP ability as well. Mainly we think of it either delivered via a mask or nasal pillows, and that is hooked up to a machine that patients use while they're sleeping. BiPAP has 2 pressures. So the first pressure is kind of like the CPAP setting. So it's a constant pressure that's given at inspiratory. So when we inhale, the BiPAP machine pushes a little bit more force to deliver oxygen. And then the second pressure that the BiPAP has is almost like a PEEP. So while we exhale, there will also be a little bit of a pressure at the end so our alveoli don't collapse. So BiPAP has an inspiratory and an expiratory pressure. BiPAP can be delivered through a few different methods, such as a tight-fitting mask, again, or a nasal pillow, similar to those that are used with CPAP. If you've ever taken care of a patient that has been ordered to have BiPAP, it's very uncomfortable. The mask is very tight-fitting, and it can have a feeling that you're suffocating, which is not good in patients who already have respiratory distress. So patients must be able to breathe spontaneously. It won't deliver breaths to them in the capacity that a ventilator will, and they have to be able to cooperate. So we don't want them pulling at that mask, right? They also have to be lucid enough that if they were to vomit, they would be able to remove that mask so they wouldn't aspirate. So we may not restrain people that are on BiPAP. The thing with that, why are they likely to vomit? Well, if we have a mask on that's pushing air into the lungs, we're also pushing air into the stomach, because we're not bypassing like we would be with an endotracheal tube. So that pressure in the stomach could induce vomiting. So we need to make sure as well that patients aren't having like a full meal and then we're putting that BiPAP on them. One of the things that is done in ICUs for patients with specific lung diseases or lung infections is proning. So positioning the patient on the stomach face down. It improves lung recruitment, which entails utilizing more of the posterior surfaces of the lungs that oftentimes might be filled with fluid. So as you can see, gravity reverses the effect of fluids in the dependent parts of the lungs. And the dependent parts of our lungs, when we're on our back, is the posterior surface of our lungs. It's very nurse intensive. It takes about 8 people to put these patients onto their stomachs. You have to think many times they have central lines, many drips, sedation. They're paralyzed, so they're on paralytics. So it's quite intense. So complications of PPV or positive pressure ventilation. So our cardiovascular system, we touched on it briefly, But if we have pressure, a lot of pressure into our intrathoracic cavity, it compresses our thoracic vessels and then decreases our blood return back to the heart. So it decreases our preload and therefore decreases our cardiac output. So that's kind of how PPV affects our cardiovascular system. Barotrauma and volutrauma, because of extra pressures or maybe tidal volumes that are inappropriate for that patient, we can actually wind up damaging the alveoli. A pneumomediastinum is air moving into the pleural space because alveoli become destructed, so air moves into the pleural space, and then that air buildup can eventually cause a pneumo. Alveolar hypoventilation is really caused by just inappropriate ventilator settings for that patient. And then our big one is VAP, or ventilator-assisted pneumonia. Just the same as we have CAUDIs and CLABSIs, we also have the VAP. So we have a set of guidelines that we have to follow in order to prevent against VAP, because if patients have a pneumonia that was associated to ventilator use, hospitals do not get reimbursed for that because it's considered our fault that they got the pneumonia from a ventilator. So some of the preventions are keeping the head of the bed elevated at least 30 degrees. Frequent oral care. So oral care every 2 hours, doing something, either cleaning their mouth or even just suctioning some of the secretions out of their mouth. Continuous subglottic suctioning means that there is a hole right before the balloon on the endotracheal tube that allows us to kind of suck out extra sputum that may have seeped down and could get into their lungs. No routine changes of the ventilator circuit tubing. That is monitored by the respiratory therapist to make sure that there's not, any buildup of nastiness in there. Sometimes if patients have a lot of gross sputum, it can kind of seep down in there and then grow in whoever knows what. So we don't routinely change them. We just change them out. It's very patient dependent. Very strict hand hygiene, which is our barrier against everything. And then draining water from the tubing away from the patient. That tubing that's connected to the ventilator and then therefore connected to the patient can develop water or condensation in those tubes. Because we're bypassing the nares, we have to heat, warm, and humidify and filter the air that we're delivering to our patient via mechanical ventilation. So that can produce condensation in that tubing, and then you can get water in that tubing, which can harbor bacteria. So we need to drain that water out. We drain it always away from the patient because you don't want to drain that back into the patient. You're going to be given the, you're draining water into their lungs essentially. So don't do that. And continuing on with our complications of PPV. So sodium and water imbalance. How in the heavens does PPV cause a problem with sodium and water imbalance? Well, when we have a decreased cardiac output, our kidneys sense it. So when our kidneys sense decreased cardiac output, our RAS system, our renin-angiotensin-aldosterone system, kicks into gear, holds on to more fluid. So that's how we can have a imbalance of our sodium and water, right? It's part of that stress response, secondary to decreased cardiac output. Our neurological system, again, our PPV can cause impaired venous return, and that's not only from our lower extremities, but it's also from our upper extremities as well. So we can have JVD or even increased ICP. It's not common, but it could potentially happen. GI system, PPV can cause stress ulcers, especially with corticosteroid use. That is very common in trying to decrease the inflammation of the lungs in many instances. And then musculoskeletal is related to the immobility that patients have while they're ventilated, and the atrophy. We do need to be conscientious of the psychosocial needs of patients who are intubated. It can be very scary. They can't communicate and talk to us. They might be feeling pain that we're unable to determine. So it's really important that anytime you're in a patient's room, and even if you think that they can't hear you and they're on sedation and pain medication, they're all doped up, I assure you that they probably can. And so talking to your patients and really assuring them, letting them know if you're going to turn them or move them, it's just common courtesy, and it really addresses their psychosocial needs and the need to feel safe. Also, it's not uncommon for patients to be paralyzed while they're mechanically ventilated, and we do that to maintain vent synchrony. So we don't want the patient exhaling every time the ventilator is trying to give them a breath. Or sometimes patients' airways are very sensitive and they don't stop coughing. Or they're so sick that we want them to conserve all of their energy, so we paralyze them, so we pretty much take over the work of their breathing. So some things to know about paralytics: we always sedate them like completely. We knock them out before we deliver paralytics or before we start paralytics. So when we give people sedation, we know how much sedation that we're giving them or how sedated they are based on their activity, right? So if I'm lightly sedated, I can probably still open my eyes, answer simple questions. If I'm down and out, you can move me all over the place and I'm still not waking up. How do we assess somebody to have an appropriate amount of a paralytic agent? We will talk about that on the next slide. There's this little neat nerve stimulator that we have that will make us twitch. It's a nerve stimulator. So what we do is we place 2 electrodes on the ulnar nerve prior to starting a paralytic. We turn up the voltage. It doesn't hurt at all. Just a little tingle. But we turn up the voltage until we get 4 twitches with our pinky, our ulnar nerve. And then based on the patient, we can titrate the paralytic to only get like 2 out of 4 twitches. So we would know that at least they were paralyzed enough. That is called the train of 4. It's a little device, and that way we can assess for the amount of paralytics they got and making sure that it's appropriate for them, because we don't want to over paralyze somebody, because then it takes longer to get out of their system, and we certainly don't want to half paralyze somebody because that defeats the purpose. All right, so then we get to the phase of weaning. So how would we know that somebody was able to wean? We'll walk through that. Your book talks about these 3 phases of weaning, which are okay in our perfect little ivory tower, but I'm not going to be, we're not going to be tested specifically on what happens during the pre-weaning and weaning phase and all of that jazz. But let's talk about the assessment. How would we know if somebody was able to wean off the ventilator and extubate? So our pre-weaning or assessment phase, assessments that we would make to help us determine that somebody was ready physically, is assessing muscle strength. So they need to be able to pick their head up off of their pillow, because that gives us a good indication that they can maintain their own airway. Assessing endurance, how long can they breathe on weaning settings? So we can tune the ventilator to only, to increase the workload on the patient and decrease the workload on the ventilator. So we can alter those settings so that they're pretty much breathing on their own. So are they able to do that all day? Assessing their endurance. Listening to their lungs. For somebody who is full of fluid or has a bunch of secretions that they're unable to handle, we're not going to extubate them. Their lungs should be fairly clear. Their chest x-rays should be fairly stable, or improved. That would give us good things, a good indication. And non-respiratory factors would be things like their cardiovascular system. So if our heart's having to work really hard for any sort of reason, or our hemodynamics are very poor, we certainly don't want to extubate somebody, because it's just going to demand more work for the heart, and it's going to increase the workload on our body. So the weaning process can either be days for patients who have been on prolonged mechanical ventilation, or sometimes patients are easy to wean because they haven't, maybe they're just on mechanical ventilation overnight because they had a really long and intense surgery. So it really depends. If somebody does require days of weaning, we generally rest them at night. So they'll be breathing on their own, hypothetically, during the day. And then at night, we would put them back to where the ventilator's doing the work so that way they could rest and be able to wean a little bit better the next day. So we do try to increase their endurance that way. During weaning, we turn off or turn down a lot their sedation. We don't want them sedated. We want them fully awake, able to follow commands, able to move around and be able to breathe on their own just as they would in a comfortable position. So most of the time we breathe better sitting up. Obtaining a baseline assessment, we kind of covered that in the previous slide about the assessment phase and what to look for. And then monitoring signs of intolerance. Usually patients who are not ready to be extubated, they'll have an increased respiratory rate, they'll be tachycardic, decreased SATs, oxygen saturations. They might be bucking the vent a lot or have asynchrony with the vent. Maybe they're coughing a lot because they're unable to handle secretions. Or sometimes just patients will let you know that they're really tired, like they're really working, using their accessory muscles to breathe. So those would be some signs of intolerance, and they would need to go back on the full ventilatory support. And they can always try again the next day. To extubate somebody, it's not nearly as much of a process as it is to intubate somebody. So upon extubation, we would hyperoxygenate them. So we would turn the ventilator on 100% FiO2. We would want to suction their oral cavity and suction their lungs. So do ET suction, deep suctioning, I guess we can call it. And then respiratory therapy deflates the cuff, and then we remove the tube after, we want them taking a deep breath in, and then we remove the tube and have them cough. So we want them coughing and deep breathing to help mobilize whatever is in their lungs out. We don't want them aspirating at all. Generally, patients are extubated to some sort of oxygen. Generally, they're not extubated to room air. They're either on a couple liters nasal cannula, or sometimes they even extubated to BiPAP because it's less invasive for patients who are, we don't want them on prolonged mechanical ventilation. And then we would monitor carefully post-extubation. One of the biggest things we would monitor for is stridor, because as that ET tube comes out through our larynx, it can cause laryngospasms, and then that would occlude the airway, and that's not good. So that stridor is that very high screeching sound that somebody would make when breathing. Once you hear it, you never forget it. It's just one of those things. It's almost like the smell of a GI bleed. So that pretty much sums it up for mechanical ventilation. We talked about BiPAP and CPAP and all of that fun stuff.